Hello there, my name is Karen, and this is the introduction training to Ovaria. So here we are getting down to basics. We are going to look at insulin, how it works in the body. We're going to look at PCOS, we're going to look at the menstrual cycle, and we're also going to look at male hormones. Watch the space for more of a data-orientated discussion on minoxidil and its effects in PCOS. This is very much the back to the basics. So I hope you enjoy it, and I hope that it helps you to learn. All right. So, of course, we are looking at ovarian health. So our focus with Ovaria is that we are supporting the patient with polycystic ovarian syndrome, also spoken or called PCOS or PCOS. It is a common endocrine or hormonal condition that has a metabolic arm, and it definitely causes reproductive disorders in females, and it is prevalent and it is seen in females of reproductive age. So when we go and look at the incidence, data says that between 5 and 15% of women of reproductive age are affected by PCOS. It varies from population to population. And the challenge with PCOS is that most of these women are only identified when they present with infertility challenges in adulthood. So they aren't managed before they get to a point where they want to have babies. What is reproductive age? Reproductive age we can gauge as between 12 and 50. So when you start regularly menstruating and when you should be able to produce babies. If we take those statistics and we apply them to the stats from 2019, we have the age group or fertile females will be around 15 million people. That means that between 1 and 2.5 million people, or million South African women, are affected by PCOS. The challenge with PCOS, though, is that not everybody comes up or presents with the same clinical issues, and there is a big variance in the severity of these challenges. So it's sometimes very difficult to identify patients with PCOS. Let's go and look at some of these symptoms. So majority of women with PCOS will have a high BMI. 80%, in fact, will have a raised BMI. Insulin resistance is a typical symptom of PCOS. Majority of the women will also only be diagnosed with fertility issues as they become adults. The leading cause of infertility is PCOS. So 50% of women that arrive at infertility clinics have PCOS as the cause to their infertility. So if we can manage them before, it will make it easier for these women to have babies when they do become adults. Lean women also have insulin resistance. All of these women can be anovulatory, so they're no longer ovulating, which means that they're no longer menstruating. Lean patients have intrinsic insulin resistance. Our obese patients have intrinsic as well as extrinsic insulin resistance. What happens is the insulin links to the fact that we have raised male hormones. And that does mean that many of these patients, between 50 and 70% of patients, will present with hyperandrogenism. And I'll tell you how to identify that a little bit later on. Most of the patients with PCOS, especially if they don't lose weight, will have complications when they have babies. So obstetric complications, they have a high incidence of gestational diabetes, and they also have a high incidence of having very large babies, which means that they do struggle with pregnancy and, of course, giving birth. Long-term, poor glucose control is related to these patients because of the insulin resistance. And also we start to see that they have high cholesterol. So dyslipidemia or abnormal blood lipid profiles, that happens over the long term. They are a high risk for type 2 diabetes, a high risk for heart disease, and long-term risks, they've got a higher risk of endometrial hyperplasia and cancer. So when we go and look at PCOS, there are really 3 groups of challenges in these patients. And we're going to look at each of these in a lot more detail as we go through this training. The first area that we have to look at is insulin resistance. So what is insulin resistance? It's an impaired response of the body to insulin. And what happens is it results in an elevated glucose levels in the blood. So let's go and look at it in a little bit more detail, but also get back down to the basics. So when we look at cells, and this could be human or animal cells, I think animals have insulin. Anyway, human cells, on the cell wall, for this discussion, there are two very important receptors. The first is the insulin receptor. Now, I've just drawn one insulin receptor on the cell wall, but there are multiple insulin receptors on your cell walls. And the insulin receptor is basically the keyhole that the insulin needs to link to, and it needs to link to it properly. And what happens when the insulin links to the insulin receptor is there's a whole process of intracellular processes that then cause the GLUT4 channel to open up. And the GLUT4 channel is the doorway to glucose getting into the cell. Now, remember, our cells use glucose for the oxidative process of metabolism. Right. So we need glucose, and we need to burn glucose to make ATP to give the cell the energy. Now, if insulin doesn't link properly, the GLUT4 channel doesn't open up, and you cannot have glucose coming into the body. So let's look at it in picture slides. All right. So here we have our human cell, and we have the vascular system. So our human cell is lying close to the vascular system. We eat some carbohydrates. All right. Of course, those carbohydrates get broken down in the gut, and they then get into the bloodstream in the form of glucose. All right. Now, that glucose flows through the pancreas, right? And what it does is it activates the pancreas to produce insulin. Now, your pancreas, the cells, or those little islets of Langerhans inside the pancreas, they don't need insulin receptors to actually metabolize glucose. So the glucose literally flows through the pancreas, and the pancreas says, okay, high glucose levels, we need insulin. So insulin is released into the bloodstream. The insulin then goes into the tissue. It links to the insulin receptor. That then causes an intracellular process that causes the GLUT4 gate to open up, and our glucose can move out of our bloodstream into the tissue and into the cell. That glucose is used by the mitochondria through a whole process of energy production. ATP is created, and the cell has the energy to perform its functions. In that process, what happens is the level of insulin as well as the level of glucose is decreased in the blood. Okay, so you have normalization of the amount of glucose and insulin. You've got happy, healthy functioning cells, and the pancreas stops to produce insulin because there's no longer this blood with the glucose flowing through it. You continue to eat, of course, it's going to continue to produce more insulin. Now, in our insulin-resistant patients, something goes wrong with the receptor. Okay, so our body's still producing insulin, but the insulin can't link to the insulin receptor properly. It means the GLUT4 gate isn't opening up properly, which means that there's very little glucose that's actually getting into the cell. It is still getting into the cell. It is still producing insulin. It is still producing ATP, but it's not producing enough. And so what happens is we've got the continual flow of, look at this bloodstream, it's got lots of glucose in it. It's also got a lot of insulin in it. Now, what the pancreas does is it goes, oh my word, so much glucose, let's add more insulin. And we increase the insulin levels, but it doesn't resolve the problem that the receptor cannot work properly. And we sit with a patient that has potentially high glucose levels. Although many patients still run on normal glucose levels, but they'll have very high levels of insulin in their bloodstream. And what we have is a cell that hasn't got the energy that it needs to produce its function. All right. So your patient is continuously feeling hungry. she's continuously eating, but the eating isn't giving her the energy that she needs because her cells can't access the energy in the glucose. And what also happens is the pancreas continues to produce insulin to a point where sometimes that pancreas will become burnt out. Okay. When your body cannot remove the glucose, what also happens is that how your body gets rid of the glucose is it puts it into the fat cells, right, in the form of glucagon. Okay, so your fat cells will take all the excess glucose and it will produce bigger fat cells. Okay, to a point where when those fat cells become saturated, they actually start releasing free fatty acids, and that's why the patient's insulin levels, cholesterol levels then increase. Okay, so we've got normal levels of glucose. So what we end up with is a patient that has normal glucose levels. She doesn't have diabetes. She's overweight though with a high BMI, and she's got raised insulin in her blood. So that's how we test our patients for insulin resistance. So what are the effects of insulin resistance? Well, firstly, our cells can't function well. All right, so cell function is definitely affected. The patient has unreasonable weight gain, okay, because her cells aren't using that glucose for energy. Her body's storing it. High BMI, she struggles to lose weight because everything that she takes in is being stored. It's not being burnt. She'll also feel sluggish. She'll tend to have very low energy levels. And we have a high risk of type 2 diabetes. And of course, the high risk of gestational diabetes and cardiac disease because of the raised cholesterol that this ends up creating. Right. How do we fix this? Well, firstly, we need to fix the insulin resistance, but also we need to she needs help with losing weight. All right. And sometimes it does mean that the patient needs to go to food jail, where she's literally just eating proteins and vegetables. Okay. So that's the first challenge in PCOS. Our second challenge is the menstrual cycle and, of course, fertility. So firstly, let's go and look at a normal menstrual cycle. So a normal menstrual cycle is anything from 28 to 34 days long, all right? 32 days. 38 days is too long, okay? That's what I'm saying. So if you go 10 days over the 28 days, it's too long. But we generally work, even though statistically there are very few females who have a 28-day cycle, I think it's around 30% of women, we do look at it as a 28-day cycle. All right. How do we measure the cycle? From your first day of menstruation is day 1, right? Your last day of menstruation, or the day before the first day of your menstruation, the day before the first day of your menstruation is your last day. Okay. All right, so you're going to count your days based on that. So always know that when you start menstruating, that is day 1. Oopsie. Let's go and look at what happens. So we have to, and this does get a little bit complicated. All right. So what happens is let's start with our ovaries. So every month, what happens is you have multiple ovaries or multiple egg cells inside your ovaries. And those multiple egg cells will become mature. They will pop and release the egg. And then what's left of that ovary will continue on and will degrade, but it produces hormones as it degrades. Right. So what happens is we have our little egg. It starts to mature and it actually forms a cyst. Okay, so this is like it looks like a water-filled cell, right, or a cyst. And when we do a sonar, we can actually see these little cysts. Okay. On day 14, if you have a 28-day cycle, that little egg pops open and it releases the oocyte, which is the little egg. Now that little egg will go into the fallopian tube and it will go into the uterus where it's going to wait to be fertilized. Right. Okay. When it is released, estrogen actually increases, all right? You can see that. So here we have estradiol. It increases, it pops, it releases estradiol. It goes down and back up again. So you can see your estrogen levels vary through this process of menstruation. Of course, the estrogen is preparing the egg, okay? You need progesterone. What progesterone does is progesterone tells the body that we are waiting for fertilization, right? Don't break down the lining of the uterus yet, okay? On day 28, or the day when menstruation starts, the progesterone decreases, right? And it stays low for the first 14 days of your cycle, right? Luteinizing hormone is produced by the pituitary gland. The neutralizing hormone ensures that whatever is left of the ovulation material actually becomes the corpus luteum. Why? Because the corpus luteum produces progesterone. All right. And follicle stimulating hormone peaks so that egg will release. Okay. If it doesn't peak, then the egg doesn't release. Right, so those are both produced by the pituitary gland. The ovaries produce estrogen and progesterone is produced by the luteal, the corpus luteum. Right? Okay. So you can see the fluctuation in hormones. Very, very important for us to maintain our fertility. When we go and look at the uterine lining, so inside the uterus, we have this lining. That lining is there for the fertilized egg to embed into and to initially use as food until the placenta is formed. Okay, so our uterine lining goes through a time period of proliferation that's triggered by estrogen, all right? Then it stays stable for 14 days while the egg will break down after 3 or 5 or 7 days, right? It will die. And then it breaks down and is released in the form of menstruation. Okay. So it's important that grows and it goes away and it grows and it goes away. Okay, so that's the normal menstrual cycle. If you have any questions, please don't hesitate to ask. All right. The challenge with PCOS is that the eggs do not release. Right. So we don't have the eggs releasing, they just stay little cysts, right? And sometimes those cysts increase in size and they actually damage the ovary, right? So the cysts don't release. And when we go and look at our hormone levels, the LH and FSH stays the same. Estrogen and progesterone start to tank out, right? Because you're not producing the levels of estrogen that you need. And that then has an effect on, of course, on fertility, but also on the fact that our testosterone becomes the more dominant hormone in our bodies. Okay. So normal menstrual cycle, we have ovulation, we have that cyst releasing, we have the hormone fluctuation. In PCOS, we have no hormone fluctuation, it just stays all the same. Okay, and that is a challenge. So our female hormones, estrogen and progesterone, are not produced in the right levels. We don't have the fluctuations, all right? So we don't have oocytes that develop into ovums, which means that there's no egg to be fertilized. The corpus luteum is not formed, which means that we don't go into the luteinizing phase, which means we don't produce the progesterone that's required to keep the lining of the uterus in place. The endometrium doesn't proliferate with estrogen, and menstruation just doesn't take place. So these patients don't produce, so that's why we talk about they're anovulatory, they're no longer ovulating, but they're also not menstruating, or they're menstruating irregularly because all the phases are out. Okay, so it leads to oligomenorrhea, which is irregular menstruations, and amenorrhea, which is absent menstruation, and of course, infertility. And that's also the leading cause to the endometrial hyperplasia and endometrial cancer. Okay, so that's menstruation that goes wrong. And then the third thing that we need to talk about is male hormones. Now, in our bodies, and in men's bodies as well, we have testosterone in different forms. Now, generally, testosterone is bound and carried by a carrier. So this testosterone that's carried by the carrier is called sex hormone binding globulin, all right? Stops that testosterone from being active. It can't link to these are androgen receptors, okay? They're not GLUT4 receptors. I should actually change them to green, all right? So free testosterone can go into the blood and it can link to a hair follicle cell, for instance, and increase the hair growth or thicken the hair. Our sebaceous glands also love testosterone, free testosterone, because of course that drives oily skin. Okay. Our voice changes if we have more testosterone. Our body, our muscle mass changes if we have more testosterone. So we need some testosterone. And our testosterone levels are actually quite high. They're 3 times that of estrogen in females' bodies. So we need the testosterone. Why do we need testosterone? We need the testosterone because it gives us drive. Okay. It also helps with our sexuality. The problem is if it becomes our dominant hormone, it causes infertility and it causes androgenism, which we'll have a look at just now. So in a healthy female, we've got a lot of testosterone that's bound and we've got some free testosterone. Right. In a female with PCOS, we might have increased testosterone, but we've also got increased free testosterone. Right. And they have an effect on hair follicles, sebaceous glands, and of course also on muscles. So what do we see? And this is driven by the hyperinsulinemia, hey? What we see is that we have raised androgens and specifically free androgens, all right? Of course, that testosterone is produced by our adrenal glands and a little bit of it is produced by our ovaries. We have less, our body makes less sex hormone binding globulin. So we have more free, which means that we have more higher levels of androgens. So how do we see that someone's got more androgens in their bodies than they need when they are females? Well, firstly, anovulation is a very good indicator of that. And unfortunately, what happens if you have so much testosterone for long term is that the ovaries they actually start to atrophy, they shrink, right? Which means that fertility becomes a challenge, all right? When I look at someone or when I listen to someone, the symptoms that we are going to look for is oily skin, uncontrolled acne, male pattern hair growth, right? So mustache, beard, hair on the neck, hair on toes and fingers, thick hair on the arms and the legs, all right? That's called hirsutism. And of course, we are going to look for infertility with long-term exposure. Right. Now, so summary of our symptoms. Okay, so those are the 3 areas. I hope that helps you to understand it a little bit more, and then I'll show you how we're going to help the lady with our myo-inositol a little bit later on. So what are the symptoms that we see? Well, infrequent menstruation or no menstruation. Painful cysts, because sometimes our cysts become very big. They sometimes have to go to a hospital to have those cysts removed, right? And in some cases, they also lose an actual ovary, right? So then that's a challenge, or it pops. Yeah, no, it doesn't pop in the fallopian tube. Okay, that one was wrong. All right. Oily skin, resistant acne, male pattern hair growth. We've spoken about that as well. Weight gain with losing weight, struggle losing weight, lethargy, tiredness, depressed mood, infertility, severe headaches, body pain. This is a very inflammatory condition. They might have dyslipidemia, so they have high cholesterol. They also have just the general body aches because they're so inflamed. And they have a lot of inflamed fattiness over their body, so fat deposits, which can also be a symptom. So you can see it's wild, it's all over the place, right? When we go and look at her bloods, she'll have insulin resistance. So from a medical point of view, insulin resistance, glucose intolerance, obesity with a high BMI. Male and female hormone levels will be out of sync, and she will have cystic ovaries. Now, the challenge is that these are the physical symptoms. All right. Many females present with vast psychological impacts. All right. So severely depressed moods. My daughter has been diagnosed with PCOS. She was diagnosed when she's 15. She's not 25. It's been 10 years of interesting. And I sometimes call her moody gloom because it can literally be so bad that she just wanders around with a cloud over her head. And we hear stories of friendships that have been destroyed because of bad mood. And it's purely related to a condition that is manageable, right? We can't remove it, we can't take it away, but we can definitely manage it better, right? So we need to look at the health and the well-being of these patients. So they do have depression, they have severe mood swings. Also, please, the diagnosis of PCOS is devastating. Right. Because patients associated with infertility, all right, and for our most females do want to have babies, all right. So just that diagnosis, I know of one of our ambassadors or one of our influencers that was diagnosed as a young child, and her mother told her to never tell anybody, all right. There's definitely a lot of anxiety, and that's because of a loss of the progesterone. We also need progesterone for our brain health. Yeah? There is a risk of having children with ADHD and autism spectrum. I don't know how well that is researched. There's definitely a lot of shame and disappointment associated with PCOS, and definitely a feeling of it's only me. Nobody can help me. Nothing I do will help. Right. So a feeling of loneliness. Okay. So after all that, how do we diagnose PCOS? Right. So polycystic ovary syndrome is for us, it's an ovarian challenge that results in an androgen overproduction, and it's all related to insulin resistance. So even though there are a small percentage of women that don't have overt insulin resistance, our focus is going to be managing the insulin resistance. But first, with all those symptoms, because she might just have oily skin and moodiness, how do we diagnose? All right, so the Rotterdam criteria for diagnosis is what we use. Okay, so there are 3 symptoms that we look for. You have to have 2 of those 3. All right, so the first one is, do you menstruate regularly? Okay, so if you menstruate less than 8 times in a 12-month period, or your cycle is longer than 38 days, you have oligomenorrhea, right? Of course, if you've stopped menstruating completely, you have amenorrhea. So don't look at her size, ask her, how regularly do you menstruate? All right. And also ask, because people go, yeah, I menstruate regularly. Then you go, do you menstruate every month? And then they might tell you, no, sometimes it's longer. Sometimes it takes 6 weeks or 8 weeks. Sometimes it looks like I've missed a menstruation. Okay, so please check that. And I really do love the cycle apps, the menstrual cycle apps, because women can follow themselves and they can work it out based on that. It keeps a nice history as well. We're not all good at keeping a history of our menstruations. The second sign we're going to look for is androgens, raised androgens. So we either strange hair growth, does she have a beard? Did you pick her up in your laser clinic because you were treating her for a beard on her chin and it's just not you'll struggle to treat it. Okay. Does she have acne? And resistant acne is a very good indicator of PCOS. Right. It just doesn't treat well. Okay. Even just oily skin would be an indicator of androgens, or raised androgens. And then the third criteria is polycystic ovarian. ovaries, sorry. And that you need to go to the gynae to have an ultrasound, and they'll have a look and see if you've got cysts on your ovaries. Now, just because you have cysts on your ovaries, it doesn't mean that you have PCOS. Okay, you have to have one of the other symptoms. You can menstruate, have irregular menstruation and raised androgens, then you have PCOS. Okay, so the reason why we don't use polycystic ovaries as the only diagnosis is that, remember, it's normal for the cysts to form. So sometimes there is one that's slightly a little bit larger than the rest. So we definitely have to look at the other criteria as well. Okay, so how are we going to, now that we know how to diagnose it, how are we going to manage it? So the first thing is that we need to look at insulin, the hyperinsulinemia. We have to lower those insulin levels, right? So that's very much a therapeutic target of PCOS. We also have to look at lifestyle, right? So your patient needs to continue to move. She needs to continue on a healthy diet. It's critical that she tries to lose weight. Okay, and she is going to struggle to lose the weight. She's going to have to make drastic changes to her routine, to her eating routine to lose the weight. And as I say, my daughter had to go, what the endocrinologist said is, you're going to go to food jail. So she wasn't allowed to eat any carbohydrates, any sugars, any simple carbohydrates, only eat low GI foods. And she did. She lost 18 kilos, 18, 20 kilos, right? And life changed completely when she did that. All right. We would also suggest that there is some medical component to this. Some patients will need to have psychological help. I love to refer patients to dietitians that have a specialty in polycystic ovary syndrome, because they can definitely help with all the components. And there are some nurses that are working with PCOS. Please look out for them as well. So at Lamelle, how are we going to treat PCOS? Well, we have a product called Ovaria. And the product called Ovaria contains 400 milligrams of 4 grams of myo-inositol. Now, what myo-inositol does is it helps to improve the insulin resistance by increasing the activity of the actual the insulin receptor. Okay, so it makes the cell more receptive to insulin, right? It also has an effect on thyroid hormones, but our major part is the fact that it is an insulin receptor enhancer. So what is myo-inositol? Inositol is a natural occurring sugar. It has no carbohydrate load though, or if it's, that forms part of the vitamin B complex family. There are 9 different forms of inositol. Myo-inositol is the one that is mostly studied. And in our bodies, in our human bodies, we have myo and dichloroinositol that has an effect on the cell wall. All right. So if you have, you have myo-inositol, you need dichloro. Dichloro will actually be formed from myo-inositol. Right. Naturally, myo-inositol and dichloroinositol are found in foods like legumes, nuts, fruits, and whole grains. Our bodies make it, right? And we are going to increase the myo-inositol so that we can help with thyroid hormone, FSH, and of course, insulin. So how does Ovaria work? It works on the wall, it works on the intracellular processes, it works on the receptor, and it helps the GLUT4 receptor open up. So that even if the receptor isn't active, it will still enhance that intracellular process, increase the binding of the insulin to the cell wall, and improve the glucose reception and metabolism of the glucose. So it normalizes the insulin as well as the glucose, and it also normalizes the pancreas's production of insulin. All right. So when we go and look at the data, there's a lot of data, and that's why I'm going to do a data presentation as well. So we know that myo-inositol improves the HOMA index. HOMA index is how your body uses glucose over a long period of time, and it looks at the fasting glucose levels as well. It increases sex hormone binding globulin, which means that we have less free testosterone available in the body. And that's with 24 weeks of therapy. So the therapeutic, all these trials were very long, between 16 and 24 weeks. Okay, so 4 to 6 months is how long the trials were. So we would suggest that patients, once they are on myo-inositol, they stay on it. Increased ovulation rates and ovulatory women. We have patients who start to menstruate from the first month that they use the product. Right. 30% of patients establish normal ovarian rhythms within 16 weeks. Right. Menstrual cycles improved 6-fold in women with oligomenorrhea. Significant decrease in androgen levels. Okay, so total testosterone, free testosterone, and DHEA. DHEA, dihydroepiandrosterone, is the precursor to testosterone. Right. Hirsutism decreased by 26% or 29% after 6 months. Right, and there were, in those trials, there were about 50% of the women that their hirsutism was completely resolved. Myo-inositol, 59% reduction in severe acne after 6 months. Please use it in combination with your acne treatments as well. So there are lots of trials. We also have trials that look at the quality of ovums and fertility treatments. So many of our patients that are on fertility treatments also take myo-inositol. And the advantage is it's a natural supplement. Okay, it doesn't, so it's a natural supplement. It's not a medication. It has no side effect profile. It is safe for anybody to use. So a 13-year-old could drink it right up to an 80-year-old. So what do we see when we are using continuous use of Ovaria? Improved ovulation. So we see fertility recovery. Menstrual cycle normalizes. Insulin resistance normalizes, and weight management becomes easier. Right. Doesn't mean she can now eat her sugar every day. She's going to have to cut down on that, but it'll make it easier for her to lose weight. Fasting glucose improves. Hirsutism improves. Acne improves. Androgen levels also improve. Okay. So a good reason to be using Ovaria. So Ovaria at this stage comes in 2 flavors. We have peach and we have orange. In each box, you have 30 sachets. So it's enough for a month. You take 1 sachet a day with any liquid. So you could use it, you could drink it in your tea or coffee if you wanted to. Most patients drink it with cold water. We all take it on an empty stomach. So you don't need to have food in your tummy to take it. And yeah, it's easy to take. It dissolves very easily. It tastes really nice. Just so that you also know it has no caloric value. So even when you're fasting, you are able to take it. And that is me. Here are all the references. We have even more papers if you need them. Please don't hesitate to ask if there's something that piques your interest. And if you need more information, check in with your representatives. And I hope to see you in some other trainings very soon. Thank you very much for joining me.